Hi, this is Dr. Gary Siskin, and today I'm going to be speaking on flow-directed embolic agents. This is the second of a three-part series on flow-directed embolic agents, and all of these lectures are part of a larger series of lectures on embolization. When we speak about flow-directed agents, we're talking about particulates or liquid agents which rely on flow to deliver that agent to the embolization target. In today's talk, we're going to be focusing on liquid embolic agents. One of the main benefits of liquid embolic agents is that they can penetrate deep into targets where catheters and coils can't reach. The thing to remember is that a phase transformation is required for most of these agents to work. In other words, we need a liquid that's low in viscosity in order for the agent to pass through the catheter, but once it's released, we need the agent to become a stiffer and more solid structure in order to obtain vascular occlusion. And of course, this needs to happen after the agent leaves the catheter. For some of these agents, there are barriers to use by peripheral interventional radiologists. This may be due to the label indication for their use. For example, Onyx is indicated for pre-surgical embolization of brain AVMs, and NBCA is indicated to reduce blood flow to cerebral AVMs. This can prevent training and ongoing clinical support by vendors. It may even prevent peripheral labs from purchasing these agents if there's no neurointerventionalist in the hospital, because of the vendor's risk of violating the prohibitions on off-label promotion. So today I'm going to be talking about a few different types of liquid embolic agents, including NBCA-based ones, ethylene vinyl alcohol ones, and absolute ethanol. So we'll start with cyanoacrylates. These are instantaneous adhesives that have been used around the world in the industrial, domestic, and medical settings since the late 1950s. The monomeric form of this consists of an ethylene molecule with a cyano group and an ester attached to one of the carbons. The ester has hydrocarbons attached to it, and the longer the hydrocarbon, the slower the rate of polymerization. It's insoluble in water, but is soluble in acetone and methylene chloride. When exposed to an anion, such as water or the various anions found in blood, polymerization is initiated with bonding of the ethylene units. This causes it to become a solid substance that occludes the lumen, and it takes just 0.087 seconds for a cast to form after NBCA contacts blood plasma. The cast that's formed occupies the lumen and adjusts to the shape of the vessel. This leads to thrombosis. Tantalum is part of the TrueFill NBCA system. Tantalum is used in the electronic industry for capacitors and high-power resistors. It's also used to make alloys to increase strength and corrosion resistance. In medicine, it's been used in dental and surgical instruments and implants. Specifically, it's been used in stents to improve radiopacity, and there's been no reports of inflammatory responses in soft tissue. In the case of the NBCA Embolic, it helps with radiopacity, and in addition, tantalum can slow polymerization. Lipiodol is also part of the NBCA system. NBCA is diluted with lipiodol to improve radiopacity and to adjust the time to polymerization once it's intravascular. Increasing the proportion of lipiodol prolongs the polymerization time because the NBCA is prevented from contacting the blood. This allows the mixture to travel further from the catheter tip, allowing longer vessel segments to be occluded. The recommended dilution of NBCA depends on the flow characteristics, the anatomy of the occlusion target, and the depth to which embolization is desired beyond the catheter tip. And this graph shows the differences in polymerization time based on the dilution ratio. So at a 1-to-1 ratio, the polymerization time can be just about 1 second, but at a 5-to-1 ratio, it could be as high as 14 seconds. The polymerization of NBCA releases formaldehyde, and this leads to inflammation of the vessel wall and the surrounding tissue. This ultimately causes an acute necrotizing vasculitis and thrombus formation within the vessel. Within about a month, this progresses to a chronic granulomatous inflammation with foreign body giant cells and fibrosis, and fibrosis enhances the effects of the NBCA. Pathologically, recanalization has been reported, especially when only partial embolization was achieved rather than total and solid casting of the nidus of the lesion. Histologically, extravascular extrusion of the glue and the development of capillaries within the embolized vessels have both been described. There are two major issues to think about when using glue. The first is the premature polymerization with microcatheter occlusion. And this is usually due to suboptimal component mixture, the delivery system that you're using, or the volume and speed of injection. D5 flushing of the microcatheter can be used to prevent this. It helps prevent polymerization on contact with blood or saline in the catheter tip. It also creates a local non-ionic environment at the catheter tip, which allows for more distal progression of the glue. Of course, if the microcatheter occludes, it will need to be replaced. It's a bad idea to try and flush out the polymerized glue, and also very difficult to do that because that can lead to non-target embolization if successful. The other problem is premature polymerization with catheter retention. In order to avoid it, you should think about a higher thiodol ratio and timely pullback of the catheter after injection. The timely pullback can potentially be facilitated by removing redundant loops in the catheter before administration. And finally, the use of hydrophilic microcatheters can help prevent this. If the catheter does get retained, you can certainly try and pull the catheter back and free it from the glue, but you don't want to use too much tension because it can cause soft tissue trauma. If the tip fractures, it can be left in place, especially if flow to critical structures is not compromised. And if it doesn't fracture, you can cut it at the skin surface and leave it in the soft tissues of the groin. A lot of the recent work in liquid embolic agents revolves around EVOH-based agents. And there are 3 agents now that are available for use. The first is the Onyx liquid embolic system. The second is FIL, or precipitating hydrophobic injectable liquid. And the third is Squid. Now, EVOH is an elastic polymer comprising an ethylene vinyl alcohol copolymer. It's formed of ethylene and vinyl alcohol. It's known for its strong barrier properties, and it has applications in food packaging, construction, agriculture, and healthcare. In medicine, it was first considered as a dialysis matrix, separating immunoglobulins from albumin, and then as a matrix for the controlled release of chemotherapy. It was first used as an embolic agent in 1990 by TechHigh. Onyx is one of the more popular EVOH-based systems. It consists of the embolic as well as DMSO, or dimethyl sulfoxide. DMSO was actually discovered as a byproduct of the paper-making process. Early studies showed some toxicity, causing it to be deemed toxic by the FDA in 1965. But now it's even approved as a standalone medication for bladder installation to treat interstitial cystitis. It also has the potential to treat skin inflammation since it can penetrate skin, and there are potential uses in the treatment of scleroderma and chemotherapy extravasation. DMSO is used in the setting of embolization to prevent polymerization of onyx within the microcatheter, which can happen if the onyx contacts an ionic solution such as blood or saline. As DMSO is administered, it's absorbed into tissues and metabolizes to dimethyl sulfone and dimethyl sulfide. 80% is eliminated within 1 week via the kidneys, skin, and breath, which is why some patients will have a garlic-like odor in their breath. It's completely eliminated within about 2 to 2.5 weeks. DMSO may be responsible for ARDS with severe pulmonary edema, possibly due to an immunoallergic reaction. And as I mentioned, it can be associated with a garlic-like taste or odor for a few days. Tantalum is the third part of the Onyx system, and in this setting, a micronized tantalum powder is added in order to maintain radio opacity. The thing to remember is that tantalum can potentially result in permanent tattooing of the skin if it enters subcutaneous vessels. Now, Onyx is available in 2 different formulations, Onyx 18, which is 6% EVOH, and Onyx 34, which is 8% EVOH. And the viscosity doubles between Onyx 18 and Onyx 34. Onyx 18 is less viscous and is used when more distal penetration is desired. It will travel more distally and penetrate deeper into the target vasculature. Onyx 34 is less viscous. It offers better control while the embolic agent is injected. This is important when the microcatheter tip is close to the target lesion or actually within it, and when a very controlled injection is desired to minimize the chance of non-target embolization. Before Onyx is administered, it must be placed on a mixer for 20 minutes. This is done to create a homogeneous solution with the tantalum powder. The next step is to prepare the microcatheter being used with DMSO. A DMSO-compatible microcatheter must be used when administering Onyx. DMSO can potentially dissolve some plastics or glues, and if a non-DMSO-compatible microcatheter is used, fractures can occur. DMSO serves as a buffer between the blood at the tip of the microcatheter and the column of Onyx entering the catheter. The amount of DMSO introduced into the catheter corresponds to the dead space, which is defined as the space from the tip of the microcatheter to the hub of the microcatheter, and this will vary based on the inner diameter and the length of the microcatheter, with some examples provided below. As administration begins, the first material exiting the catheter is the DMSO. This must be injected at a very slow rate of about 0.1 milliliters per minute. A faster injection can cause displacement of the DMSO, which can lead to vasospasm and severe pain. This pain is due to endothelial irritation, which potentially leads to endothelial necrosis and inflammation within the wall of the artery. With fluoroscopy, it's possible to note the transition from DMSO to Onyx, and once the Onyx polymer begins to leave the microcatheter, the injection rate can be maintained or increased, but to no more than 0.3 milliliters per minute. As Onyx is administered, it's not carried by blood flow. Instead, it displaces blood by the pressure applied by the operator. And as you can see in this diagram, it advances a little bit forward, but also refluxes slightly back around the tip of the microcatheter to form that initial plug, which can then be pushed forward slowly by injection pressure. It fills the vascular lumen and doesn't adhere to the arterial wall. It hardens on the outer surface first and gradually gels towards the core over several minutes, and the plug itself has a foam-like consistency. The whole solidification process takes about 5 minutes. And this is what it looks like on the outer surface and that gel-like consistency on the inside of the plug. Onyx itself has a weak inflammatory effect on the endothelium, but the DMSO can cause a more aggressive response. By forming a cast of the vessel, thrombosis is not that important to the occlusion caused by Onyx. As a result, its action is independent of underlying coagulopathies or low platelet counts. The next EVOH-based agent to discuss is FIL, which is precipitating hydrophobic injectable liquid. This is composed of a copolymer that's covalently bonded to an iodine-containing component, which is on there to provide intrinsic radioopacity, so no tantalum is required. This agent does require DMSO, though, to prevent premature precipitation. Just like Onyx, the distance traveled before solidification depends on the flow rate in the vessel, the position of the microcatheter in the lesion, the rate of injection, and the viscosity of the product. FIL polymerizes from the outside in to form a block, and final solidification of the injected agent occurs within 5 minutes. FIL comes in 1 cc pre-filled sterile syringes, which are accompanied by DMSO syringes as well. There are 3 formulations of FIL based on the concentration of the polymer by weight. There's FIL 25%, 30%, and 35%. And as the number goes up, the viscosity goes up. So you would use FIL 25% in low flow situations, and you would use FIL 35% in higher flow scenarios. FIL and Onyx both cause a mild to moderate inflammatory reaction due to the DMSO, and the one associated with Onyx is greater than the one associated with fill, and fill does not tend to lead to angionecrosis. It has been shown to penetrate smaller vessels than Onyx. There are several potential advantages to fill over Onyx. Fill doesn't require shaking since it doesn't require tantalum, and that means it can be used faster with less prep time than Onyx. The lack of tantalum also means that there is less glare or artifact on CT, and the flow is different than what we see with Onyx. Onyx demonstrates a lava-like flow with a plug forming at the tip of the catheter before it propagates forward. Fill behaves more like a viscous liquid, more like toothpaste. This implies that fill can be injected faster than Onyx. And fill is a yellow-colored liquid that won't stain the skin if it's used in more superficial vessels. The newest EVOH-based agent is Squid, and there are 4 different configurations of Squid. There's 18 and 18LD, and 12 and 12LD. And the LD versions have 30% less tantalum, which may help visualize structures behind the dense embolic casts. Squid 18 behaves similarly to Onyx 18. Squid 12 is less viscous than the available formulations of Onyx. And remember, the higher the number, the faster the cast solidifies, and the lower the number, the greater is the ability for it to spread and propagate distally. Squid Peri is a peripheral formulation of Squid, and there are case reports that have been published describing its use in the peripheral circulation. The micronized tantalum particles that are used with Squid are smaller than those used with Onyx, and this may help provide a more homogeneous solution, and the precipitation is slower than seen with Onyx. All 4 variants of Squid induce fewer beam hardening artifacts than Onyx 18 on CT, which is a potential advantage of its use. I would also like to talk about ethanol in this lecture, and ethanol, as you know, can be used as a sclerosant and as a permanent embolic agent. There are several factors that influence the efficacy of ethanol. It's always best to use minimally diluted ethanol, which is 95% or more. The depth of penetration and efficacy increases with the volume of ethanol that's used. The local concentration in the abnormal vascular bed will influence its efficacy, and the time of contact influences it as well. The efficacy is better when flow in the target vessel bed is slow or even absent. The injection rate also impacts the efficacy of occlusion. A low flow rate is defined as less than 5 cc's per minute. This leads to prolonged contact with the vessel with focal destruction that tends to spare the perivascular structures. A higher flow rate, greater than 5 milliliters per second, can cause perivascular necrosis. In terms of the technique of injection, balloon occlusion is something that's commonly used in association with alcohol. On the arterial side, balloon occlusion can control the flow of ethanol, prevent reflux, and increase the contact of the ethanol with the vessel wall in order to accelerate thrombosis. On the venous side, balloons can be used to occlude the venous outflow, and this can be considered if there's rapid systemic drainage of the lesion that you're treating. If this is the case, then constant pulmonary arterial monitoring is recommended. When using alcohol, occlusion occurs due to the following mechanism. Protein denaturation occurs, and endothelial damage occurs as well. The ethanol interacts with lipids in the endothelial cell membrane, which decreases the surface tension and causes dehydration and rupture of the cells with precipitation of their protoplasm. The result is exposure of the subendothelial tissue and necrosis of the vessel wall. Alcohol also leads to vasospasm, and ultimately all of these mechanisms lead to thrombosis. There are risks to the use of ethanol. The local risks include damage to nerves, skin, and mucosa due to its penetrative properties and the perivascular necrosis I described before. And systemic toxicity is increased when the dose is greater than 1 cc per kilogram, or if the total volume is greater than 60 milliliters. The side effects can include CNS depression, respiratory depression, seizures, hemolysis, and cardiac arrhythmias. I would also like to spend a few minutes talking about Gelfoam. And in that neat classification system I've been presenting in these lectures, Gelfoam is kind of an anomaly because it can be classified as either a mechanical agent or as a flow-directed agent, depending on the size and preparation of the Gelfoam used. Gelfoam is a water-soluble agent prepared from purified skin gelatin. During manufacturing, nitrogen is bubbled into the Gelfoam sponge to obtain a more porous structure, and this enables absorption of up to 45 times its weight in blood. It leads to hemostasis by hastening the development and providing structural support to clot that forms once it's in place within the vessel. Gelfoam was first used as a hemostatic agent in 1945, and this was published in an animal study evaluating the effectiveness of Gelfoam to stop bleeding in canine livers. The first embolization procedure with Gelfoam was in 1964 during an occlusion of a CC fistula. Gelfoam is typically prepared in one of two ways. The first way is through the use of pledgets, where larger sized pieces of Gelfoam are cut and put into a syringe with contrast and saline and then injected as more of a mechanical embolic agent. And the second way it's prepared is as a slurry, where pieces of Gelfoam are placed in one syringe with contrast and saline, and then the contents of that syringe is passed back and forth through a stopcock into another syringe to create more of a slurry or paste-like agent. And when it's done that way, it acts as more of a flow-directed agent. In other words, when you cut cubes of Gelfoam and mix them with contrast, you can get them to be as small as 500 to 2,000 microns. But if you take larger cubes and then pump them through a stopcock at least 30 times, you can generate particles that are smaller than 500 microns in diameter. When Gelfoam is introduced into the target vessel, it induces a necrotizing arteritis and foreign body reaction that peaks within 3 weeks after administration. The one thing we know about Gelfoam is that it's considered the original resorbable agent. Vessels embolized with Gelfoam typically recanalize within 3 weeks to 3 months due to enzymatic degradation. However, a permanent occlusion has been reported after Gelfoam use, and this may be secondary to an aggressive inflammatory reaction. In other words, the Gelfoam may go away, but the occlusion may not. In addition, a permanent occlusion can be associated with overpacking of the Gelfoam. Finally, there's a risk of infection associated with Gelfoam use, and this has been attributed to the long exposure of porous Gelfoam to contaminated air. Fortunately, the incidence of this has decreased with improvements in sterile technique. In conclusion, liquid embolic agents represent a new opportunity for interventional radiologists to expand their capabilities in the area of embolization. Understanding the technical nuances associated with the use of each of these agents and the different agents that are available will enable appropriate selection based on the pathology being treated and the anatomic variations encountered on a patient-by-patient basis.